You're watching the Randy Alvarez podcast. I'm Randy Alvarez. Today's topic is what you need to know if you're considering dental implants, but it's a bit of a different twist on things. And you know, for 27 years, I've been interviewing dentists about dental implants and medical doctors about a variety of different topics. And this is one of those things that's really evolved over time. And when they come on my show, the typical thing is they talk about eating and chewing and laughing and dating and kissing and all the nice parts about it. But there's a downside or an other side of implant dentistry where the teeth fail, where the implants don't work. They get infected. The way the teeth come together are all wrong. Different materials are being used so that way they crack and they break. And so I invited Dr. Briskie on the program today because he's one of these teachers, lecturers, key thought leaders when it comes to implant dentistry. He lectures. In fact, I ran into him recently at the Neodent conference, the largest implant company in the world, and he was lecturing to other dentists across the country. So I thought, who's the perfect person to come on here to give us the inside scoop? I don't want to scare people away with this. And Dr. Briskie, I want to welcome you to the program.
Yeah, thanks a lot, Randy. Appreciate you, my friend. It's nice to talk with you again on the Wellness Hour.
And look, I don't want to scare people away with this, and that's why we don't talk about it on our shows, because, you know, as we've said before, you know, they weren't even thinking about implants failing, meaning not working, falling out, or whatever, until we bring it up. But I think it's important for people to know, because now it's no longer a question of whether implants are good for tooth replacement. It's a question of who we should go to. So let's start a little bit with you first. Let's talk about your, as a trainer, what do you teach? What do you lecture? What are your topics to other dentists?
Yeah, of course. So I own an institute. It's called Colorado Surgical Institute. It just reached its third birthday. So it's been going for 3 years, which I'm really proud of. And we teach implants, wisdom teeth, sedation. We also teach sinus surgeries and some other complex stuff as well. But my passion has always been the full mouth of implants, especially zirconia teeth. And that's one of the main things we get.
Okay.
We teach for.
Now, when I ran into you at that big implant conference, what was your lecture about?
My lecture was actually on how to prevent surgical errors. And what I've noticed a lot of the time is when someone gets a new set of teeth, a lot of the time they get a denture. So they think they're going to go in to get permanent teeth, but they walk out with a denture. So my lecture was how to effectively look at your surgical plan for the doctor and anticipate those issues. Therefore, no patients will have dentures again.
Okay. All right. You know, it seems like, it seems like that people choose their implant dentist based on advertising, based on who's got the biggest ad, who has the most ads, who has the best website. Is that frustrating for you? The experience part of it?
Yeah, I'm smiling because I just had a guy 2 days ago. He walked in and he's like, you're actually decently close to my home. I went to 2 different implant centers. And then I asked him, was like, who answered the phone call? And he said, I think it was a sales guy. I just started laughing. I was like, because it's a little bit unfortunate. I think sometimes when we have all the sales people answer the phone, we're walking away from the personal aspect of the practice. And I love my private practice, and this is what I do every day. But we try to make it an actual relationship and not one built on a sale.
Now, for the sake of this podcast, I want to limit this to people that are considering getting an upper and lower set of teeth supported by dental implants, that it's been determined that the teeth they currently have are bad, they have to be removed, and they don't want dentures or the denture wear and their options.
Yep.
I want you to talk first about a lot of these Google advertising trends. Like in Los Angeles, California, we're in San Diego, there are billboards that say $295 an implant.
Yeah.
Can you talk a little bit about some of these low-priced bait and switch style advertising, what your thoughts are?
I just get a little bit disappointed. And you see a lot of them, especially in our state, they'll say, oh, get a whole new set of teeth for $14,999 or something like that, right? But then when you show up, they say, oh, well, you actually need bone grafting, so now it's this much extra. Or, oh, you want to be asleep for the procedure? Now it's this much extra, right? Or you wouldn't believe the amount of patients that have a set of temporary teeth in their mouth. they think that they're the final or zirconia set of teeth, but it's just
What
not.
does that mean, by the way, a temporary set of teeth?
Yep. After surgery, everyone in my office will leave the office with a new set of teeth, but that set is going to be a temporary set. We allow it to be the first set having it temporary because after swelling, the gum and bone will go up and down swelling. Then after a few weeks, the gums settle down and you get food stuck under your teeth. So we will first make the first set of teeth of a temporary, then we'll make a second temporary.
How long are those supposed to last, by the way? These temporary teeth, like when you print, I guess you print in your office.
Yes.
When you print that full arch of upper teeth or lower teeth, how long are they designed to last?
Those maximum, I would say 10 weeks, maximum. Okay. And I see a lot of patients that will be having them in their mouths for 6 months to almost 2 years, and they have a ton of plaque around the implants, and we're having now implant failure because we're not doing the right thing for the patient.
So when I see ads, back to the question about these Google ad trends, are you saying that what they're advertising is really this temporary set of teeth, and then you got to pay an extra 15 grand later to get the zirconia teeth that you're offering? I don't want to put words in your mouth. Is that kind of what's going on?
Unfortunately, yes. Yeah. I wish there was a little bit more transparency.
Now, what about this like $295 an implant I see on billboards?
Yep. Well, when we see that, the first thing that I always think of is like, hey, where did they get their implant from? Right? Did they physically fly over to China, buy 10,000 implants, and we're putting some implant substitute in there? Or it's just another misleading price where it's just the surgery, right? Maybe they're advertising just the surgery cost and they're doing it at a certain financing amount, right? So maybe they could get their costs down to as low as $295. Right. So again,
but do you think $295 is just part of the price? Maybe and some of them are only quoting you what that little titanium screw costs, yeah, possibly?
Exactly. Yeah. And usually it's just for just the surgery. It's not really including the tooth on top.
You know, I talk to doctors, and this is kind of happening across the country, this misleading advertising. Do you think it's going to go away?
I really hope so. I really do. I think I have good belief in our professionalism that we can maybe not have this. I think it's just reached a point where it's at its probably highest right now.
Now, I've done the research on this topic as far as pricing. I know what you're charging, and you're 10 to 20% less than the big guys, right? Yep. Is that fair to say?
Yeah, actually, yeah, a few $1,000s less than every big guy around me, which is great. I teach implants for a living, so I get mine for a little bit cheaper from the #1 implant company in the world. So, and I also do all the work in my own office. Therefore, that goes down to just a nice cost savings for all my patients.
Okay, now we're going to talk about experience in a moment, but technology. Mm-hmm. Not all offices have the technology you have, where they do it all right there. Could you kind of tell me like the differences, what's going on in the industry as far as technology? And
yeah,
why and what it matters to the patients, as far as what impact it has?
Yeah. So there's this implant company named Straumann, and each state has one office that's called a digital education center, and that's actually my office. So I'm Colorado's digital education center. So I teach dentists how to do this digitally. And the biggest thing that I see missing is 95% of cases of patients who go to get same-day teeth, they walk away with a denture. So the doctor will put implants in, they'll grind the denture out, and they'll cement it to the implants. But that's very dirty, and it still looks like a denture, right? So what we do here is I have my own set of printers and scanners. Everything is digital, and I print a set of custom teeth for every single patient that has a surgery. Therefore, it looks nicer. It's way stronger. It's made out of ceramic instead of a old school type of denture material.
Tell me this, because you use terms like digital. You've also used terms like analog. What does that mean to the patient? Like, what's the difference?
Yep. The digital way is just the newest way of doing something.
Is that being done on a computer? Is that another way of saying it's done on a computer?
It is. Everything is done with a computer nowadays in my practice. So I don't use impression material anymore. If you've ever been to a dental office, or anyone listening, You get all that gooey stuff in your mouth, right? And that tastes like a paste. I don't use that stuff anymore.
What do you do?
5 years now. I use a special 3D scanner. It's a scanner that's a wand. I put it in and around your mouth, and it scans your teeth. So therefore, we don't have to have all of that pasty stuff in your mouth.
Okay. Is it a more precise way to do it?
Way more precise. Yep. It's down to almost 5 micrometers, which is very, very, very precise.
What are other technologies within a practice that patients need to look for before they choose a dentist?
Having a CT is very, very important, right? I do see a lot of patients will go in for a consult and their dentist will say, oh, we'll see what we can do, right? But that's not good enough, right? I like to tell a patient, hey, this is how many implants you're getting, right? This is where I'm going to put them. And I do that all on the first visit. Also
I'm sorry, but what's the difference between an X-ray and a CT? It sounds like an obvious one, but in the world of dentistry, what's the difference?
Yep. So traditional X-ray, which is what most people take, or a panoramic X-ray, is just a 2-dimensional X-ray. You can just see just the front, kind of like if you're looking at the screen right now. But a CT is a 3-dimensional, right? That's where you can turn your head and you can look in the bone and around the bone and see how wide the bone is, or how tall the bone is, or how soft the bone is, or how hard the bone is, right? All of things that you need to know going into the surgery day so you can make sure your patient leaves with teeth.
So what's other technology that they need to, ask the doctor, do you have this? You mentioned things like photogrammetry or tell me what this means.
Yep. The biggest thing is, I would say, number one would be a CBCT. The second would be having the 3D printer available to print that person's teeth. The third would be having a scanner that can scan the teeth rather than taking a regular impression. And then the fourth one would be that word you just said, which is called photogrammetry. I know it sounds kind of scary, but all it is back in the day when an avalanche hit and a skier got trapped underneath the snow, what we used to find them was called photogrammetry. It triangulates the position of where they are so they can be found and saved. And now we actually use that same product in dentistry now, and we use it for implants.
Like how so? I mean, does it make things more precise? If you go to one dentist that doesn't use that and one that does, how can it affect the outcome?
Yep. So when the teeth are meant to sit on the implants, now when you use photogrammetry, there is 0 error in that scan. So it's down to 5 micrometers, which means there is no rocking of the teeth on the implants. They fit perfectly right on top of them. What most dentists do is they'll use old school materials like impression materials or different cements or composites or filling materials. But all of those have a shrinkage rate. So if you put that in someone's mouth and you take it out, it's now not as accurate as if you were to just scan it in the mouth. So it's just a way more precise way to give someone teeth again.
Now, just so I understand this correctly. Okay, so by using this photogrammetry, hope I'm pronouncing it right, you're able to place the implants in the correct position. And by using this, the teeth that go on top are more stable. So if they're going to be eating and chewing for the next 40 years, does it make it last longer? Or is there any data to support that it's a better, longer lasting set of teeth?
Yeah, the better that it sits on the implant, the less that it could wiggle the implant, right? Because if you're chewing side to side all back and forth, and if the teeth don't fit on the implants correctly, you could actually lose implants over a period of time, right? You'll get bone loss around them, or you could break your new teeth you got. So it's really nice to take out all of that error by using a machine like this. Therefore, there's no breaking of the teeth. Your implants can't break, right? It's just a very, very accurate
Does this happen? How common is it across the country and especially you're a trainer. I mean, some of the guys that go to your courses, their implants break. By the way, is it the implants break or is the teeth that go on top are breaking? What is it?
It's usually the teeth, and you can almost see it in this picture right here. Right here, there's actually, this little piece is broken right there. It's supposed to look like this little circle. This is a patient's teeth I just had come in yesterday, and their teeth are broken right there because of this reason, right? It wasn't seating correctly, and then it just broke because they're trying to put the teeth down, but it's not fitting, but they still try to put it down, and then they break the teeth. So this patient came in, and I just found those yesterday.
So you couldn't, that would be very difficult to do with the naked eye, just by eyeballing it?
You can't notice these things just with the naked eye. You'd have to allow the patient to chew and then snap, right? If something breaks, and you think it's the patient, but I think it's very unfair to blame the patient for something that we should have the professional knowledge for.
Does this happen a lot with some of your students?
Quite a bit. Most still don't know what this machine is. I was one of the first docs in the entire states. There were 10 doctors that first got the first machine, and this was about 5 years ago that I've been using it. But most doctors think that this is still a very, very brand new thing, but we've been using it for about 5 years now.
I got to back up to something you said because I didn't know this. So you mentioned Straumann. Straumann kind of owns Neodent. Is that correct?
Yes.
So this is the largest implant company organization in the U.S., maybe the world.
In the world.
And
yep.
you said and you're a center, what?
It's called a digital education center.
Okay.
That's Straumann named my practice that, the one in Colorado. So each state has one practice, which is that, and that's mine.
So by the way, look, you knew you were going to be on this program, on my podcast, and you knew that we were going to talk about, the inside scoop and what could go wrong in the hands of inexperience or whatever.
Yep.
Like, what did you want to say? Like when you're thinking, I want to make sure I get this point across.
I would say most patients will Google an implant dentist, right? And they'll say, oh, the guy next to my neighborhood does implants. I'm going to go see him. But what they don't realize is the level of surgery, it differs drastically. And most patients, how they find me is they're willing to drive an extra 15 minutes to find my office because I do this every day and I teach it every day. So as opposed to a majority of doctors who do implants may average one set of zirconia teeth each month, right? I do 8 to 12 a month, right? And I also teach this for the past 3 years now. So the level of surgical knowledge does vary very greatly. Is what I've been finding. There's probably about maybe 10 offices in the state that are actually doing this really good. And then if you look statistically in the United States, I would say in the United States, for all 50 states, there's probably less than 200 dentists that know how to do this well and do this every day. So, right? So that it gets a little bit, it makes me a little nerve wracking. I really want the patients to find the right person.
Is that right?
Whether that be me or someone like me in a different state.
Now, I know that people, when they have heart problems, maybe they go to Mayo Clinic, or if they have, some type of cancer, they go to MD Anderson. People travel for serious things.
Yeah.
Are people traveling for this type? And is it encouraged to travel to find since there's only a handful of guys in the country doing it at this level right now?
Yeah, because we know how to get the visits down. It may seem like it takes longer to get to the office. You make up for it in the amount of visits that it takes to get the set of teeth done. Have patients that come from the mountains up way as far as Leadville, which is, it's like 4 hours away. I have people coming down from Wyoming, people down from Aurora on the very, very outskirts of the cities, right? Because they know that we can get the visits down and we can do a really nice job. That way they're not having to keep coming back over and over and over and over again for something that should have been done right the first time.
Now, there's the printing of the teeth that you have for technology, right? And the fact that you have that on site rather than an outside lab. I guess how it's normally done is you send it out. If there's a mistake or if there's a problem, does that cut down on time?
It does. So the best way to explain this is, let's say Thanksgiving is coming up, Randy, and you're like, oh my God, we're at Thanksgiving. I got my new set of teeth. I'm so excited to chew. And then snap, like you break your teeth. Maybe you ate something you weren't supposed to. Maybe you're chewing on ice, right? Something really, really hard. And then you call your dentist and your dentist says, oh yeah, I can make you a new set of teeth, but it's going to take a week to get you a new set of teeth because I'm using a lab, right? So if you're using an outside lab, it's going to take quite a bit of time. But what happens to my patients are, if they break their teeth, they call me and I say, hey, head over. I'm going to print your set of teeth right now. So that way, by the time they get here, I give them their new set of teeth and they don't miss Thanksgiving dinner.
It's all set that way. Now, there's also like you work together with another lab that like mills the teeth, the final set of teeth. Is that correct?
Yes. Yep. The only part that I don't do in-house is just the milling material, the milling at the very end. So the zirconian teeth has to be milled by a very, very special machine. So that's the only part that goes outside of the office.
But they're not inconvenienced with that because they're out using their teeth that you made in your office
Exactly.
in the meantime.
Yeah.
And then the other one, so they just come back in and get their new teeth, which is their final permanent teeth.
Correct. I used to own a few mills. And to be honest with you, sometimes it's a positive, sometimes it's a negative. It just depends on where you can find the best material for your patient. And right now, because of all the relationships I have with teaching, I can get the best material by setting it up right now.
Okay. Now on the phone, let's move over to experience for just a moment. Mm-hmm. I think you told me that sometimes an inexperienced dentist doesn't know if it's soft bone or if it's hard bone. They put in the wrong implant. It's like 20 appointments just to get it right. And you're saying that you could do the whole thing in as little as 2 or 3 appointments. Can you talk about that?
Yeah. So it just reminds me of, she's one of my favorite patients ever right now. And she's who I used at my presentation for Neodent. Her name's Jean. And Jean had about 3 to 4 different surgeries. She had a few implants placed, lost a few. Put another few implants in, she lost a few. And then she finally found me and she said, hey, I feel like I'm going crazy. What's going on? Why don't I have teeth yet? So when you looked inside the 3D scan, you could see how soft the bone was. The bone was like cardboard versus concrete. So I told her, I was like, hey, we're going to be great. Don't worry. We're going to do your surgery next week and you're going to have teeth right after the surgery. She didn't even believe me. She woke up and she was crying. It brought me so much joy to have someone smile like that, but it's just because of a surgical error. The bone was very soft, therefore we can't get a stable implant in soft bone if you don't know how to place it correctly. And I think that's what's called a surgical error. But what I know is how to get stability of an implant in any scenario. So I think that's why these patients, some of them have bad experiences, is because if the doctor doesn't have the 3D scan to know how to anticipate those problems, the patients won't walk away with teeth.
Look, everybody has to start somewhere, right? You started somewhere. Are you that much better now than you were several years ago?
Yeah, way better than a few years ago. I think I would even compare it to fillings. So a lot of dentists will do a filling, right? I don't think I really got very, very, very good at fillings. I think it took about 4 years before you placed a really nice filling that looked nice and the bite was perfect, right? And that was something that is more simple as opposed to a filling. So imagine the learning curve that it takes to place an implant, yet alone an entire mouthful of implants. So I'd say it probably took about the first 200 cases until I felt very, very, very good about the outcomes. I'm up to about 800 cases now.
Is that right?
And it just kind of keeps getting better, and you change little things every few months. I'm still changing things as new technology comes out.
Have you ever in your career had a patient say, how many of these have you done?
Yep.
Really?
I get that question quite a bit because I still
Is that right? I didn't know that.
Your side, and then I show them the Surgical Institute stuff and how many cases I've done. I'm like,
oh, I see.
Yeah, but I tell them, hey,
but is that a fair question? Because that takes a lot of nerve, actually. And I was trying to put myself in that position. Would I be able to, if I was getting a knee done or something, would I say, how many of these have you done? Do you think patients are intimidated to ask that question? And should they ask it every time?
Yeah, they should 100% ask that, right? There's a big difference if you've done 10 of these in your life versus 800 of them, right? Big difference.
Now, what is the biggest mistakes that your students make in implant dentistry? If you could share them with us. If you had to say there were some mistakes, what is it?
I would say getting stability of your implant. And for everyone listening, if your implant isn't stable in the bone, the patient doesn't walk away with teeth that day. I see that quite often, where the patient will say, oh, great, I'm going to go in for my new set of teeth. But then they wake up and then the doctor says, hey, so sorry, your bone was too soft. We're going to have to wear a denture now for the next 3 months before we can give you something.
That happens a lot?
It happens quite a bit. more than really people will ever admit. That has only happened to me 3 times out of the past 800 arches, actually. And all 3 of those were actually over 3 years ago now.
Are most dentists just doing it like how most of us learn things, learning by our mistakes?
Yeah, I mean, to be fair, I think we all learn by all of our mistakes, right? No one ever wants to do something poorly, right? And we all want to do really good for our patients. But some of us just aren't there yet. Maybe we will someday, but we're just not there yet. Some of us.
But the technology, like you mentioned, photogrammetry, which allows you to place the implants in the so-called perfect position, that eliminates a lot of these mistakes?
Yes, yeah, quite a few. Eliminates a lot of the mistakes. That way the implants are in the right position and the teeth are in the right position.
Now it's a big investment. What do you say to dentists? And maybe they're going to watch this. What do you say to them that say, well, I'm going to get photogrammetry later?
Yeah. So it's funny you said that. I'm just like, gosh, my face is almost turning red with how much money I had to spend to start my practice with all the correct instruments, right? Because that machine itself costs $50,000 just to get that one piece of equipment. And man, if there was anything in the practice that I wish I had, it is that. That's how much time it saves me and for my patients.
What would it be like in your life as a super busy guy doing this if they took away your digital printer that makes the teeth in the next room and they took away your photogrammetry? What would your life be like? What would it be like to practice implant dentistry?
I might retire at that point or just go full-time teaching, I'd probably say. I don't think I could go back to that. Oh my Lord.
Really? But 9 out of 10 practices, if not more, like 999 out of 1,000 practices, do it without those 2 things.
Right.
Do you think they don't get it, or they're just not at that level to make the investment? What is it?
It's usually a philosophy of the practice. It's that either they don't want to make the investment, or they've been doing it so long that they've been unwilling to make the change and learn something that might be better, right? So some people are a little bit stubborn.
Okay, let's talk about bone grafting for a moment. I was talking to a dentist in New Jersey, and he said, Randy, he was all fired up about something. He goes, this poor patient spent $10,000, 1 year worth of bone grafting, and they still didn't even get 1 implant.
Yep.
Can you speak to that?
Yeah, it all comes from anticipating what the actual solution will be for the patient. There's so many cases that I can think of where doctors have asked me, like, hey, how can I get this patient teeth in this site again? But they'll try the wrong thing, right? They'll try a graft that was the wrong technique, or they'll try to do sinus surgery that was the wrong technique, not knowing of what's going to happen or the surgical outcome that will happen. And then they get a poor result. Then the patient has all this wasted time. So I think over the years I've learned what is going to work and what's not going to work. So that way I'm not promising my patients something and then they're spending a bunch of money, right?
Can you help me understand, maybe I'm wrong about this, but is there less bone grafting today than there was 3 years ago, 5 years ago, 10 years ago? And why is that the case? And why are some guys doing a ton of bone grafting and sinus lifts and all of these things, complex procedures, working in and around the sinuses, and now there's less and less of it? Mm-hmm. Explain that to me.
So in a full mouth surgery where the patient is getting a new set of teeth or a new set of zirconia teeth, I haven't done a sinus lift in I think just over 1.5 years, actually, because there are new techniques and new types of implants you can place. Therefore, you only have 1 surgery rather than 2 or 3. So majority of the doctors will still do the old school techniques with all the sinus surgeries, all these big bone grafts, all of that. They give their patients teeth again. But it's gotten to the point now where the surgical skill set, if you find a doctor with that surgical skill set, it's 1 surgery now rather than 2 or 3.
Would you say that across the country, thousands and thousands of sinus lifts are being done that could be avoided with the newer techniques?
Oh yeah, big time.
Yeah. How sore is that for the patient? Like what is a sinus lift? Mm-hmm. What does the patient need to know about it?
Yeah, of course. So a sinus lift, if you hard boil an egg, if you ever hard boil an egg and then you take the shell off, then there's that little stringy thing on the outside of the hard boiled egg. It looks like a little soft cover. You have to take that
Okay.
off. That's what the sinus is. It's a very thin membrane. And what happens in dental surgery is if you don't have enough bone for a full mouth of implants, you'll have sinus lifts on both sides. So you have to go in through the bone. You lift up that really thin piece of membrane that looks like the outside of a hard-boiled egg, and then you pack bone underneath it. Right? Then you just cross your fingers that things work really, really well. But we've gotten to the point now where I will only do the sinus surgeries for 1 or 2 implants. I won't do it for a full mouth because there are other techniques to put the implant in that are more or are just as successful, right? Or more successful because we have less surgeries now. My
So then
patients.
why, but that, I mean, everybody must know this, right? In the world of dentistry, or no?
What's that?
I mean, this seems like common, is it common knowledge? Because logically what you said makes sense. So why aren't all these people, the thousands and thousands of sinus lifts that are being done every single day, why aren't they learning the newer technique?
Most just can't do it yet, right? They just can't do it yet, right? In terms of the technique. That's when I was talking about the number of dentists that could do these types of procedures, right, in the state or versus in the country. There's just not as many of them, which is fine, right?
Does it add more risk or danger to the procedure when you do sinus lifts?
I'd say when we do those longer types of procedures for the patients, or if we have more and more surgeries, the less chance of us becoming friends at the end of it is. So what I've found is by doing one surgery, I am way better, way more likely to become friends with my patients rather than doing 2 or 3 surgeries.
Now, when I had you on my program on the Wellness Hour, right, we talked about eating and chewing and how it really impacts a patient's life and their self-esteem and their charisma, and they smile more, and they get new jobs, and those things take place. But do you ever get patients, because look, you're an instructor, do you ever get like people send you x-rays or CTs or whatever, or you see the patient live and you just shake your head and go, I can't believe they did this? Does that ever happen?
It does. I try not to verbalize those things though, right?
Well, that's what this podcast is for. I think the public needs to know that things could go wrong.
Mm-hmm.
And so is that like once a week, once a month, where you look at it and you go, I can't believe this?
Yeah, it's one of those things where it's like you don't know what you know until you know it, right? And for a lot of times in the teaching world, the student just doesn't know what it should be looking like or what the outcome should be. So yes, I do see that. I'd say at least once a week because we do.
Oh my goodness.
Calls, and I have a lot of text messages that just go on all the time with people asking me about the cases. But yeah, unfortunately, I do see that.
I mean, do you think there's a lot of this going on? But you know, a dentist isn't going to tell everybody about his problems he's having in his practice or with his patients, right? So a lot of this is kept. I don't want to sound like a conspiracy theorist, but a lot of this is just kept under wraps, right? You don't hear about it. Is there truth to that?
Yeah, there is a little bit of truth to that for sure, right? Because I think in the profession we all want to help each other and help our patients. And same thing, we may just not know what the surgical outcome should be yet. That's why the experience plays in so heavily. Because the more and more cases you see, and the more these scenarios play out, you just know which method to go with.
So at your training center, I guess monthly or every 3 months, you have patients and you do live surgeries. That means these patients oftentimes have a full mouth of really bad teeth. You remove the teeth, clean up the infection. I'm making it sound simple. Place the implants, put the teeth on top, all in one day. And you do that in front of a bunch of other dentists that are learning this to witness. Is that right?
Yeah, we actually, so the first day of our classes for the full mouth of implants, I do a demo surgery for the top and the bottom. So they watch me do a surgery. And then they get to do it the next day. It's just funny because I'll do it in, 3 hours. So then when they go, it's, 6 or 7 hours.
Is that right? So look, and these patients that are there live and these are regular people, right? That you select, they get their new upper and lower teeth that don't come out in 2 appointments. Is that correct? Yes. Ideally?
Yep, ideally too.
So you meet them, determine whether they're a candidate, you take measurements or whatever you do, and then they get their new teeth that day. So they walk out or get wheeled out because they have sedation with upper and lower teeth that don't come out.
Right.
Is that how it's typically done in your own private practice? where like it's a 3-step process, 4-step process? Tell me about that.
Yep. Yeah, usually just 3 steps, right? Because first we have to meet you to know what you really want and what is best for you, and how we can work out things to accomplish this, right? And then we have the second visit, which would be the surgery and getting your new set of teeth, all right? And then later down the road, we give you your final set of teeth, which are made of zirconia.
Okay, so the final teeth are completely different than those temporary teeth, which are being sold online at Google as your teeth that you're getting that are upper and lower teeth that don't come out. So you have to be careful. Those things break, right? They're only meant to last 4 months?
Yeah, I'd say maximum I would recommend would be about 3 months. Yep.
What are your thoughts on, I have this on my question, mini implants? What are they? And, I hear stories of great on eight mini implants. And I had one guy tell me, Randy, everything's getting smaller in medicine and in surgery. And he loves these mini implants.
Yep.
So what are your thoughts? Because I've never met anybody else that likes them, but it's a movement going on to save money, I guess.
Yeah. So when you have mini implants, I like to call them more temporary implants because they're in for a little bit, but it'll be only for a few years. Usually those types of cases where doctors are placing mini implants, they'll last about 4 or 5 years. But then it comes to the point where the implants are becoming lost now because they're too small. And the patient still has a denture, right? So this whole time they don't have permanent teeth, they still have a denture. So mini implants will help secure a denture, but it will not be a permanent set of teeth. So a lot of the patients will find someone later down the road to put permanent type of implants in after the mini implants go bad.
We're in San Diego. The border of Mexico is an hour away. I've been told by my friend, Dr. Chris Henninger, that people are going to Mexico every day to get their implants done, and then he repairs them.
Yeah.
What do you think about this travel, this tourism dentistry, or whatever they call it? And what do people need to know about that? Because I only hear the negative stuff.
Yeah, I think the first thing is I think everyone wants teeth so bad, right?
Okay.
And then they struggle to find an office that's a little bit more affordable like mine. So they start to go outside of the United States. And what happens is you have to book a flight and a hotel, and you have to go for all these surgeries and visits. But what if something doesn't go right? And that does happen quite often. So the cost to get something repaired by someone in the States after things go down south is very costly. So you have to pay for a set of teeth over there, and you have to pay for a new set of teeth when you get back. So I just had a patient with the same circumstances.
Really?
She got some surgeries done in Venezuela, had implants on the top and on the bottom place. She lost 3 on the top and 1 on the bottom, then went for a second surgery where she got all the rest of the implants replaced on the top, got 1 new one on the bottom. The bottom one failed again, and then all 4 in the upper failed again. But she was just told, hey, this is your fault. You are doing this wrong. The patient,
what was she doing wrong? What do you mean?
What's that?
What was she doing wrong?
She wasn't doing anything wrong.
No, but what did the doctor, what could she be doing wrong? What did the doctor say?
It was soft bone. So the doctor didn't know how to get stability of the implant in the soft bone scenario. So the same topic that I lecture about. So the patient kept having implants fall out.
Yeah, but she saved $3,000. Yeah, but she saved $3,000. So it was all worth it.
Yeah, see, now she's spending quite a bit more because that office in Venezuela, they're not going to give your money back, right? They say, oh yeah, money back guarantee, but they know someone coming from the States, if something goes wrong, you're not getting your money back.
Where you are in Colorado, is that common too? People will travel? Do you hear those stories?
Yeah, I do see it. It's not very frequent, I'd say, in the state, but it's usually more someone like where you just said, someone maybe living in San Diego, or it's like a 1 hour, 2 hour flight away. But still, you have to remember that this is in a different country, right? If there's issues, who's going to help the patient with that? Also, too, a lot of the patients will get new set of teeth, but they're not told how to take care of them. If you go overseas, you get your implants. A lot of patients think, hey, I'm done forever. These are my teeth forever. But that's not true. You have to get your implants cleaned. Just like you clean your teeth, your implants have to be cleaned as well. So a lot of the patients who go outside of the States or go to a really big corporation, like the big guy implant center, they aren't set up with a way to clean their teeth afterwards. And then they lose their implants after about 4 to 5 years. So
Is
my
that
practice
right?
is a little bit different where we place all the implants, but I also take care of them over the years to make sure nothing goes bad.
Okay, so going to you, let's say, even though you're, let's say, at the top of the game, you teach dentists from all over the country, it doesn't cost more to go to a guy like you. Even at the beginning, it doesn't cost more. But getting it done right the first time is a lot less money in the long run. Is that right?
That's correct. Yep. A lot cheaper, right?
And this is so confusing because I guess the technology differs so greatly in inexperienced people that the public doesn't know the difference. That's the challenge, right? And that's probably not going to go away anytime soon. So final thoughts here. Is there, sedation. I got to ask you about sedation because before we went on, I said, I was talking to a dentist and he says he doesn't sedate his patients. He just numbs them up. And in my mind, look, I have zero fear of the dentist, but I was thinking, I did nitrous one time for a deep cleaning. I loved it. And now for everything I do, I get the nitrous, right? Just takes the edge off. Yep. So do you think it's insensitive to only numb somebody up? I mean, I want your opinion.
So in our courses, in our teaching, what we used to do was we used to do no sedation, or we would do oral sedation, which is just some pills. And what we noticed was the patients always started to feel something around that second to third hour, right? So the patient would be miserable. They can feel things. They're tired. They want to go home, right? So nowadays, in my private practice and in my surgical institute, you only do sedation. And there's a difference in sedations too. There's a type of sedation where the doctor puts an IV in and they give you some medications like midazolam and fentanyl, right? But you can still remember what's going on. So nowadays, I only recommend a anesthesiologist type of sedation where we give propofol, so something that's a little bit more safe, and you have a 0% chance of remembering anything.
Is that right? Now, but it's still an IV. Is that right? It's not like
still
a tube down their throat.
But the drugs are way better and more healthy. And the one that does the sedation in my office, since we do it all the time, it actually costs less than the standard way of getting sedation.
So is it worth it for you as a doctor? Like if somebody, if you know that the anesthesiologist is right there looking at their blood pressure, their vital signs, their oxygen levels, does it allow you to do things more efficiently? Is it better for you as the doctor? Obviously better for the patient.
It's so much nicer to just focus on the surgery and knowing that my patient's health is just taken very, very well taken care of. I can just go in and I have a game plan for the surgery and I execute my game plan and I make sure my patient leaves with teeth.
Is this one of those procedures that's like a 90% success rate, 98% success rate in the hands of somebody experienced?
Yeah, it really is. So even the 10-year data right now is 97%.
It almost works every single time.
It really does. Over the past 2 years at my private practice, of my new office that I'm in now, I only lost 3 implants out of over 400. So it's over 99% in my own office. And then
okay.
Yep.
Look, you seem like a humble guy, but I'm gonna try to get you to brag about yourself for a second. I had a plastic surgeon on my show from UCLA, and he told me, he said, Randy, because he felt like he was like one of the best in the world, secretly. I mean, he's not going around telling everybody this. This is what he confided to me. But he goes, there's like a great high school quarterback, and then there's Tom Brady, right? Or there's a high school gymnast that wins all the local meets, and then there's Simone Biles, right? It's like some people just have it. They're Olympic. Do you feel like you're one of those guys, like at Olympic level when it comes to implant dentists?
No, I wouldn't say that. I don't think I would ever say yes to something like that. I think my mom or dad would fly here and probably slap me for trying to say I'm Tom Brady. I'm too humble to say that.
But there's different levels in skill and hand-eye coordination. Is that true?
Yeah, there's definitely either. I would say in all the teaching stuff, I would say you really know you can really start to pick out those students in the room when we do the teaching stuff. I can look at the room of students, and after the first day, this guy's going to get it. And then you start thinking, oh, these ones may not get it, unfortunately.
How could you tell
It's
that,
more
by the
like
way?
an innate sense. It's like a sense of confidence and humbleness. If
Okay.
you have humbleness and confidence, it goes a long way. But in return, I do unfortunately see a lot of people who don't have the confidence or who are arrogant, right? If you're arrogant, you can't learn, and you're not open to learning from your own mistakes. I think that is one other thing that I noticed a lot. So it's the ones who are humble and a little bit more confident are the ones usually that are successful, not the ones that are very arrogant.
Okay, Dr. Briskie. So if you're going to an implant dentist, find out what kind of technology they have, like an in-house lab. Find out how many they've done of the procedures. Is that correct? Find out their stance on tons of bone grafting versus minimal bone grafting. And find out how many steps to get to the finish line, how many steps to get to those temporary fixed teeth, and then the final permanent zirconia teeth.
Yeah, and make
Did I
sure
leave
you ask
anything
what
out?
type of teeth you're getting, right? Ask like, hey, what type of teeth am I going to be leaving with? Are they denture teeth or are they ceramic teeth, right? Like something printed that looks really nice. That makes a
Okay.
big difference. And also,
All
how
right.
many implants do you get? I'd say most providers will place only 4 implants. It's called an all-on-4, right? We've heard that term, and many people who are out there, please make sure you ask this. But if you place 4 implants, the minimum number of implants you need to have a new set of teeth is 4. So if you lose one, now you have no teeth. So I've learned
Oh,
over the years I always place 6 implants. And the reason is if you lose one, God forbid, you're one of the 1% of people that lose the implant, you still have teeth throughout this entire journey. So it's just something I'm just not willing to risk.
and it's not that much more, right? These little tiny implants only cost about $180, $225. Is that right?
Yeah, depending on the level of the quality of the implant, yes. So it's like some docs will care about 200-300 bucks, right? When I just don't think it's a big issue.
Okay.
So I don't think I'm not gonna purposely withhold 2 implants just so my patients, just so I could save a couple $100.
Now there's the last thing, and it's a big topic, but we'll try to shorten it up, is this remote anchorage, they call it, or like zygoma or pterygoid implants, where they're tacking the implants. Sounds terrible to me, by the way. Tacking it onto their cheeks and things like that. Do you
Yeah,
think that's being overdone? What are your thoughts about it? And do you know how to do those type of implants?
I do know how to do those types of implants, all of them. However, I still think 99% of cases do not need the type of implants that go in the cheekbone. There are more than enough ways to put an implant in a unique position, which I know how to avoid those. And that's like last resort nowadays. I think there's trends in surgery. Zygoma implants used to be talked about more in the 90s. You may remember this from a few years ago, Randy. Like some docs a while back, even 20 years ago, they were placing those types of implants. Then there was a wave where they didn't, and it's because they learned from their mistakes and when to place certain implants and when not to. So I think what we can learn from our previous predecessors, right, our peers, were that zygomas do have complications to them. So it's a last resort implant. But I would still say 99% of the time you don't have to use that. But if you do,
Okay.
I can still do it, but I will try to do something else first.
So with experience comes judgment, right? Knowing how to treatment plan a case ahead of time.
Yep.
And is judgment common sense, or it only comes from experience? Or is it a combination of both?
I'd say it only comes, I'd say probably 20% of it comes from the book, right? Is you can see something, how it's planned in the book, then you start learning from your own mistakes over the years. So 80% of it is actually learned. It's not from the book itself.
Okay, good. Dr. Briskie, I want to thank you so much. So if somebody makes it this far, a patient watches this thing, they could fly into Colorado, get their teeth done in as little as 3 appointments. Is that right?
That's correct. Yep.
Okay. All right. Well, thanks a lot for coming on the podcast, and good job. I learned a lot today. So good.
Awesome. Thanks, Randy. I really appreciate you.